The first thing you're going to want to do is grab the most up-to-date SubQ DKA order panel. This is occasionally updated based on feedback by people who are implementing this protocol. And so this is really just designed to make your life as easy as possible. In order to do this, you're going to go to the Epic tab. You're going to go to Tools, and then Preference List Composer. You'll go down here to Copy User Lists. You will take it from me, Madison, with 2 T's, first name Nathaniel, and then you're going to give it to yourself. In this case, we're going to use Dr. Stenard. Scroll down to Orders Inpatient. Click that box. Make sure this says Merge. So if you have any order panels or order sets, you don't delete those. And then you'll go down to Copy. You can close that out. You can go back to your order panels. This is all the order panels that you'll have. You can double check that it's there, and it's called ED DKA SubQ. And you can double click that, and you'll see that this will have most of everything that you'll need to do the SubQ protocol. The only thing that this does not have that's absolutely needed is the D5 normal salt order, and that will be different based on if you're at Shreveport or Monroe. Okay, so we've made the diagnosis of DKA and we've determined that the patient is suitable for the protocol. And so we're going to put some orders in. So we'll go to our order panel. We will type in ED DKA SubQ and enter. Here it is. Double click on that. Dismiss that for now. All right. And so let's go through our orders here. So first thing that we do for these patients is they're likely dehydrated, and so we're going to give them some plasma light boluses. 2 liters is kind of the default, but just make sure that's appropriate for your patient. This is just kind of a little reminder if they have other comorbidities that would prevent them from tolerating fluid, then don't give it to them. Or if for whatever reason you think they need more or less than 2 liters, then that's fine. But for most patients, 2 liters is going to be a good starting point for fluid resuscitation. And then we'll have our insulin orders. And so we have insulin aspart. This is the 0.2 units per kg. We will be giving that every 4 hours until their DKA is resolved, which we'll talk about. At the same time as aspart, you're going to be giving Lantus, and this will be either 0.3 units per kg, or if they're on a home dose of long-acting, we're going to use their total daily long dose. And so, for example, if they're on 20 of Lantus twice a day for whatever reason, then in this patient, instead of using the 18 units, we're going to use 40 units because that's the higher of the two. Here we just have some nursing communications, basically just serving as reminders to keep giving the aspart until the DKA is resolved, and that's defined as the bicarbs greater than 18 and the anion gap is closed or less than 15. This also is a reminder to give the D5 IV maintenance fluids even if the patient is hyperglycemic, because by the time that we give them all this insulin, ideally they will not be, and likely they will not be, and they'll be at high risk for developing hypoglycemia. And so if you're in Shreveport to order the D5 maintenance fluids with electrolytes, we will use this INV electrolyte R in D5 with additives. So we'll type that in right here, and that pulls up here. And then you have to click on that, and you have to first decide what additives, what electrolytes this patient needs. And this chart is here. It's also in the handout. And then you'll scroll down to these options. And for most patients, potassium phosphate is going to be the one that we use. And so let's just click on that for that. So this will automatically give the dose 15 millimoles added to the D5 Normasol. And we'll be running that at the same time as our Plasmolite or electrolyte A infusion. And we can toggle how much Plasmolite we give in relation to how much D5 Normasol we give. And so most patients will be able to tolerate 200 to 250 milliliters per hour, depending on how dehydrated they are. And based on what their glucose is, we can either give them more D5 per hour and then less of the Plasmolite in order to have a total of 200 or 250 milliliters per hour of total fluids. We will want to be monitoring for hypoglycemia and hypokalemia, and so we will be checking glucoses every 2 hours, renal function panel every 4 hours, and then just one magnesium. No need to repeat that. Something different about this protocol compared to how you might have been taught in residency is we're going to feed these patients as long as they can tolerate it. You're going to feed them basically whatever they want, because that's going to prevent hypoglycemia. And so we'll treat they typically have nausea and vomiting. There's some PRN medications built in. So the D50 is a little different than what we're typically used to. The PRN's written for less than 150 as opposed to less than 70, just because we want to prevent hypoglycemia. We also have PRNs written for electrolyte abnormalities. You will need to still tell the nurse to give it, but let me know if these are more annoying to address, to have to delete off the order set. You'd rather just read off of the handout, or if you enjoy having these PRNs available. If you have any questions, don't hesitate to shoot me an email. Or if you do end up using this protocol, please email me the MRN of the patient. Thanks.